Hi, this is a video lecture on infections specifically aimed at after childbirth as well as the infections that could contribute to preterm labor. First off, we'll talk about infections that happen after childbirth. 8% of births in the U.S. are affected, and it's even increasing number with those that have a C-section. Anything over 100.4 temperature should be considered a febrile process, especially after the first 24 hours. And the things that we'll probably be talking about here is endometritis, wound infection, mastitis. We're not really going to talk about upper respiratory infections or UTIs, just like briefly. The risk factors for your postpartum infections or your puerperal infections are prolonged rupture of membranes and long labors, like anything that's like 18 to 24 hours or longer. Urinary catheterizations. Again, remember we've talked about this. That's why we spent a lot of time in sterile technique as well as not contaminating the field. Anemia, obesity, smoking, drug use. It reduces the body's immune system. C-section, it's like an alteration in the tissue integrity. Other operative deliveries, poor nutrition because the body can't fix that tissue, diabetes because it decreases the body's ability to heal, postpartum hemorrhage, regional anesthesia, which has a decreased perception to void, and increased risk for urinary tract infection and also like secondary to urinary stasis. Everything in the reproductive tract is connected. So the vagina, the cervix, the uterus, the tubes, the ovaries, as well as the peritoneal cavity. And usually infections are ascending, so it could affect any and all. Also, something to consider is like when staph is ill, like H1N1, COVID, flu, anything like that. A lot of that plays a big role in that. The first thing we're going to talk about is endometritis. This is an infection of the lining of the uterus. It usually starts at the placental site. It's localized initially, but it can spread. This is pretty much your most common one. Fever, chills, increased pulse, anorexia, lethargy, foul-smelling lochia. These are just some of the symptoms. Antibiotics, fluids, warmth is like really the treatment that we do. Supportive care, like just allowing them to rest and giving them some pain relief because especially if it's endometritis, their uterus is tender. So cephalosporins, penicillins, clindamycin, and Jents are the medications that are used. Wound infections, the most common when a woman is already home. So that's why education is really important. This can be a C-section incision, but most often time it could be a repaired episiotomy or a laceration site. So again, the RETA, so the erythema, edema, warmth, tenderness are just some of the signs and symptoms. You might see the incision not approximated where there's like a wound separation. They could have a wound debridement. I mean, if it gets bad enough, depending on the severity. Perineal care, so it's really important that we teach good hygiene practices, signs and symptoms of worsening condition, antibiotics, fluids, pain medication are all really important. Education is extremely important. Mastitis is probably the most common one that you'll see, and hear about. These breast infections are rare in non-breastfeeding moms. And it's due to an improper latch. So part of the Bubble Hearts assessment is looking at the nipples to see if they're bleeding or cracked, blisters, things like that. The breast doesn't empty, blocked duct, and that is due to this improper latch initially. Okay, it's usually unilateral, and it's usually in breastfeeding moms. Edema, inflammation, pain. It might even feel like there's a knot. Sometimes you can kind of rub it out, if it's early, or a warm shower will help kind of alleviate that. But broad spectrum antibiotics are needed, fluids, pain medications. Usually you feel better within a couple of days, provided you get treatment. Treatment is focusing on a couple of things. One, emptying the breast and controlling the infection because it could go into an abscess, and it could be pretty significant. Women can still breastfeed even though it's pretty painful. So most women try to just pump it out and empty the breast. But again, increasing the frequency of nursing is really important. Antibiotics, ice, and warm pack, whatever is going to help that mom. Okay, so that is mastitis. Urinary tract infections, again, we have to teach proper care, signs and symptoms to report, the frequency, the burning, the pressure, dysuria, potential complications. It could actually go up into like a pyelonephritis, a kidney infection. So it's E. coli is the most common bacteria, and it happens just because the urethra opening, the vagina, and the rectum are very, very close. So this is that. As far as nursing care for infections, its teaching is really important. Prevention is best. Good nutrition, good hygiene. We need to be able to assess for risk and teach. Women will go home before sometimes these symptoms start. So it's really important that we give them signs and symptoms to report, things to look for with infections. Talking about getting into some of the STDs, herpes is one that we talk about. Many cases continue to rise. However, women who have positive herpes but don't have any lesions, we're starting them on acyclovir earlier in the pregnancy so that they don't have a lesion at delivery, because this is one of the contraindications of a vaginal delivery, is having an active lesion in herpes. Herpes is it is pretty significant if a baby comes through the vaginal tract and gets herpes, severe neurological deficit. It's spread by direct contact of the skin or mucous membranes, especially with an active lesion. There is tons of cases every year. If a woman gets herpes for the first time in her pregnancy, it's very, very likely, like 30 to 50% chance that she will pass that on to her newborn. If she's had herpes for years, there's like a 1 to 3% chance. So it's like kind of like a super infection right away. But again, rupture of membranes. If rupture of membranes happens and there's an active lesion, that could actually go up. So it's really important that people self-report. It's very important that we look for any complaints of like itching, pressure, things like that for them. Again, the CDC recommends a vaginal delivery in the absence of an active lesion. HPV is another one. It's genital warts. Nothing really much on this one. There's a vaccine that's available. Pregnancy can cause it to increase. A baby coming through the vagina and in contact with HPV can cause laryngeal tumors. Also, this is the one that can lead to the dysplasia that can cause some forms of cervical cancer. So that's why there's a vaccine available from the ages of 9 to 26 years old for both boys and girls. So that is one of them. Syphilis is that one that's kind of like on the rise again. It occurs like in 4 stages, like primary, secondary, latent, and then tertiary. The symptoms often vary among individuals. Like in primary syphilis, may present as a single painless lesion or chancre, multiple or uncomfortable lesions. Okay. Secondary is individual may have a rash, and it's like this copper colored rash, like on the palms of the hands and the feet, even the mouth or the rectum. Latent syphilis is asymptomatic period that may last for years. And then tertiaries may affect multiple organ systems, including the brain, nerves, and joints. We were on a mission trip and we saw a toddler who had syphilis. He wasn't walking and he had like these shark-like teeth, and he was severely developmentally delayed. So it is a shot of penicillin, and that's why we do that RPR, that VDRL, both in their prenatal labs and when they come into labor. Gonorrhea and its best friend chlamydia kind of go hand in hand. This is gonorrhea and chlamydia are the ones why we give erythromycin eye ointment. We don't just say to our patients, just because if you have gonorrhea or chlamydia, we just say just for any infection that the baby's coming through. So with gonorrhea, it could cause that ophthalmia neonatorum, which is that newborn blindness, a baby coming in contact with that. With chlamydia, a baby could get that conjunctivitis. So that's why we treat them with erythromycin. And it's just like a simple, antibiotic as well, too. So that will take that. We don't use tetracycline during pregnancy. Trichomonas is another cause of vaginitis, flagell. It could cause any of these infections, and the reason why we bring them up can cause preterm labor, premature rupture of membranes, and postpartum endometritis. So that's why we kind of bring this up. Remember, every infection is ascending, and we just talked about the reproductive tract, so that's why we talk about this. The one that you're going to see a lot is the GBS, which is the group B streptococcus. Every woman has a form of strep in her vagina and her rectum, and that helps keep everything clean. It's just when you have this overwhelming colony of this bacteria that could cause trouble for the baby, not for us, okay? So there is, they have to be treated. So we check them between 35 and 37 weeks, whether it's in their urine, whether they do a culture. So if they're positive in their urine, positive in that culture, either or both, we're going to treat them during labor. And we try not to break their water or push this delivery until they get 2 doses of penicillin in. Now, if they're allergic to penicillin, then they get something else. They get like vancomycin. So again, really acute assessment of the baby afterwards, because there's early onset GBS and there's late onset GBS. It can cause because remember, babies are born with a weakened immune system, so therefore they can't localize infection, so it comes over as generalized sepsis. So we're talking pneumonia, a type of form of meningitis type of thing, okay? Babies die from this, okay? So if they're not treated, then that's an issue. Now, everybody is cultured, not everybody's treated. So if a mom is coming in, who's GBS positive and comes in for her day of admit surgery, she's not treated because they're delivering that baby before, the chance for that infection to get up. However, they will watch that baby for a couple days. There is some, when you have people who don't have prenatal care or we just don't have any kind of records, we look for risk factors. So if they're early, like less than 37 weeks, if they've had their water broken for more than 18 hours, if they have a fever greater than 100.4, or if they had a delivery of a previous GBS positive baby, we're going to go ahead and treat her for that. HIV and AIDS, what we know is that people living with HIV and AIDS continues to grow, and of those people, many are of childbearing age, and of those people, many acquired HIV from their mothers. Mostly in other countries, that's happening. Strides in treatment are being made, but you're not seeing it on the news as you once did in the early 90s. But please believe me that HIV and AIDS is every bit a threat as it was almost 30 years ago. There is still really no cure. Without going into the total pathology of the disease, the gist of it is that it disables the immune system. It's progressive and it's debilitating. With pregnancy, research tells us that HIV doesn't proliferate to AIDS and AIDS doesn't proliferate into death. But once infected, antibodies are detected and it's confirmed. And in this country, which is nice, if they're going to getting adequate quality prenatal care, they're getting this type of medication, which that they'll deliver this baby who hopefully will not be positive in 6 months, but we'll get to that. Perinatal transition from mom to baby has decreased in our country due to like AZT, I call it an AZT cocktail, but not so fortunate in other countries, okay? So having treatment does help our pregnant moms and our newborns. The CDC, the World Health Organization, says that you shouldn't breastfeed. However, in poorer countries, the risk of starvation versus AIDS, they're going to feed their babies with the breast. There's a lot of things. Birthing methods are provider preference. So whether or not you're going to have a C-section, whether you're going to have a vaginal delivery, you want to eliminate some of the like breaking their water, putting a fetal spiral electrode on it, because mom's blood and baby's blood, you don't want to do that. So we're going to try to reduce instrumentation as much as possible. But again, with proper treatment, we're seeing these babies, like at 6 months, maybe negative or no evidence of any type of of disease present. We may see our babies a little, they might come a little bit early, they may be a little bit small, but counseling, education, birthing methods, counseling, what's going on in their life, how they got HIV in the first place is paramount to the success of having a healthy baby and a healthy mom. Preterm labor, why we bring preterm labor up with this, because infection is a leading cause into why labor might happen. Labor, we define preterm labor as greater than 20 weeks and less than 38 weeks. So 20 weeks 1 day to 37 and 6 kind of thing, okay? Preterm births were up initially, and since 2006 have dropped down to about 12%. Late preterm. So we have in your book, it talks about early term, late preterm, early preterm, all that. But what we're seeing is we're seeing issues with limiting scheduled C-sections or inductions to 39 weeks unless indicated, using strategies to prevent preterm birth, in improving fertility models. Okay, who's getting all this fertility meds? You know, you have these high order multiples is not really good either. Okay, so that's one of them. So the other thing too, women at risk, poverty, lack of education, lack of access to care, history of preterm birth, African American gals, living in poor areas, infections, pre-existing diabetes, pre-existing like hypertension, previous C-section with a classical incision, any type of placental disorder, advanced maternal age, are all women who are at risk. Poor nutrition, age, less than 16, greater than 40. So all of these are some of the signs that the women are at risk. Signs and symptoms are more subtle than regular labor contractions. So again, we look at constant back pain, pressure, change in discharge, a sense that something isn't right. Cramps with or without diarrhea are just some of the signs and symptoms that we might see. What we can do is we can drink water, we can rest, lay on the side for 1 hour to see if contractions have kind of stopped. If they continue, you want to call your doctor. If they go away, take it easy for the rest of your day. Managing preterm labor, there's a lot of things that we do with that. We can measure cervical length through the ultrasound. There's this test called fetal fibronectin, and it's a glycoprotein that it's found in blood, and it's found early and late in pregnancy. So this kind of tells us if a patient is going to deliver sooner than later. So when it's found in the late second trimester and early third, it could be a sign that preterm birth is coming. So it's not that good of a predictor, but it does give us something to go on. Okay, but progesterone supplements. Progesterone is really important in this too, because progesterone injections on people who have a history of preterm labor or preterm birth, progesterone keeps the uterus quiet. So sometimes they get weekly injections of progesterone. There's no clear first line of tocolytics. Drugs may prolong labor, but do not prevent it. They may delay it a little bit, but not a lot. A lot of times when we give medication, we'll give magnesium sulfate, which we'll talk about in class. Some of the medications that we give, magnesium sulfate or whatever, is that we try to get at least 2 doses of steroids 24 hours apart in order to accelerate fetal lung maturity. But magnesium sulfate, nifedipine, indocin, tributaline are all meds that we have used in trying to halt preterm labor. That's something that we'll talk about in class. And let's see, I think that might be it. Oh, if we have premature rupture of membranes, one of the things too that we're going to look at is why does preterm premature rupture of membranes happen, or prolonged rupture of membranes happen? We don't really know. The cause is unclear. However, infections decrease the integrity of that amniotic sac. So that's one of the reasons why this might happen. So it's an issue when you have a baby that's 21 weeks versus a baby that's 32 weeks, okay? So one of the things that that we're going to look at is, what could have caused this. So when you have somebody who is preterm prolonged rupture of membranes, you want to know what the gestational age is and is there an infection present. So a lot of times the management is nothing in the vagina. Once all this starts, avoid breast stimulation, take the temperature frequently, look for signs and symptoms of labor, and look for signs of infection. So again, looking at fever, uterine tenderness. That's it for this one. We'll talk more in class.